Hello and welcome to the introduction lecture of the Anatomy and Radiology Contouring Bootcamp. I'm going to start today by talking about why we need an anatomy bootcamp. Our specialty of radiation oncology has changed over the past 20 years, and we design radiation in a completely different way. 20 years ago, radiation was designed like this, using fluoroscopic images and bony landmarks. You didn't necessarily need to know the fine details of 3D anatomy for this, but things have become much more complex. We moved from there to 3D planning, like you see here, and then to IMRT, where we can avoid things like the parotid, like the spinal cord and the oral cavity, but only if we know how to delineate those. But contouring is complex, and if we do it wrong, it can lead to harm. I'm going to show you one example of that here in this case report called Gastric Perforation Following Stereotactic Body Radiation of Hepatic Metastasis from Colon Cancer. You can see here on the left that the authors treated a liver lesion with stereotactic radiation, but they didn't contour the stomach. Not contouring the stomach led the algorithm to dump dose into the stomach, which caused a gastric perforation, and you can see that here on the CT. On the right, you see the postoperative specimen from the repair, where you can see some liver on the outside, but there's a hole in the liver where you can see the stomach, and a hole in the stomach wall where you can see the rugae. Contouring is complicated, but our anatomy instruction has not kept up with changes in practice. We saw that in this trial, RTOG 0529, where IMRT was investigated for treating anal canal cancers. Treating physicians had to submit plans before their patients started treatment, and as part of the planning, they had to delineate normal structures like the small bowel, the femoral heads, and the iliac crests. And you can see an example plan here showing the areas to receive 54 gray, 45 gray, and 50.4 gray. When they opened the trial, the investigators found that the first 5 cases submitted were all incorrect. And you can see an example of that here, showing an incorrect mesorectal contour in red. The correct one, you can see around that in green. This led them to create an online atlas to help the enrolling investigators. But overall, when the trial finished, they found that the majority of cases, 81%, required revisions, and about half required multiple revisions. 8% of them ultimately never passed. What types of errors did they make? Well, the GTV was contoured incorrectly in about 1 in 5 cases. The elective nodes were often incorrect, including the mesorectal, presacral, inguinal, and iliac nodes, and the normal structures were often misidentified, including the small bowel and the large bowel. This shows us that contouring is hard. And we also know that if our plans don't comply with protocols, outcomes are worse. We see that in this analysis of the TROG 0202 trial. They looked at patient outcomes from their trial based on whether the plans were compliant with the protocol. The line in red shows survival for patients whose plans were expected to have a major TCP impact, a major tumor control probability impact, and those patients clearly have worse survival. Interestingly, the study also showed us that practice makes perfect. The high volume centers, those enrolling 20 or more patients, had a very low rate of plans with major deficits, only 5%. But in the low volume centers, enrolling only 1 to 4 patients, the rate of major deficits was much higher at 30%. I'm going to show you a clinical case now that illustrates how our contouring has changed and why we need to be able to locate intricate anatomic structures. This is a patient of mine who had an adenoid cystic carcinoma of her palate that extended up to the base of skull. You can see that on her left with tumor going all the way up, whereas on her right you see normal muscle and fat planes. And you can see a similar finding on this axial slice. When you go to contour a case like this, you use the CT and the MRI reports to guide you. Let's look at the MRI report. It says that tumor invades the left maxillary sinus, the left inferior meatus, and pterygopalatine fossa. The left foramen rotundum is enlarged. Abnormally enhancing soft tissue extends into the most anterior and inferior aspect of the left cavernous sinus. Meckel's cave remains normal. Tumor infiltrates the most anterior attachment of the left medial pterygoid muscles. So when you contour, you need to be able to identify things like the pterygopalatine fossa, the foramen rotundum, and the cavernous sinus so that you can cover the tumor. Years ago, we recognized the need to modernize our anatomy teaching in radiation oncology, so we launched a pilot program in 2011 and 2012 that included multidisciplinary lectures with anatomists, radiologists, and radiation oncologists, along with hands-on anatomy labs. Then we did a poll of Canadian residents to gauge their interest. We asked them, What is your level of enthusiasm towards attending this bootcamp on a scale of 1 to 10? 1 being not if you paid me, 5 being neutral, and 10 being I would skip my own wedding. And as you can see here, there was significant enthusiasm with about 10 residents saying that they would skip their own wedding, showing a very high level of dedication. So we created a formal bootcamp course. It consisted of large group didactic sessions, this one led by a neuroradiologist. And the lectures were often multidisciplinary, and you can see here I'm teaching alongside our neuroradiologist, Dr. Tay. There were small group cadaveric anatomy labs led by anatomy graduate students where we learned the anatomy, but also the radiologic correlates. And there was live contouring with feedback. The course is broken up into sections including head and neck, thorax, abdomen, and male and female pelvis. Each section contains video lectures, anatomy labs led by anatomy graduate students, contouring, and knowledge checks with quizzes. We even have a pre- and post-course contouring exercise so you can see how your contouring has changed after taking the course. This course was originally designed for radiation oncology residents, but we found that the audience is much wider. It is geared toward anyone who needs to learn about anatomy and radiologic correlates. This includes radiation oncologists, radiation therapists and dosimetrists, anyone studying radiology, and medical students. The in-person bootcamp actually became part of the curriculum for our CAMPEP medical physics PhDs, and we also had attendees who were advanced practice radiation therapists who do contouring themselves. Our goal is not to teach you every contouring protocol for every tumor site. There are dozens of protocols and they change over time. Our goal is to teach you the anatomic and radiologic foundations so that when you read a protocol, you can find the areas that you need to treat and the areas you need to avoid. For contouring, we're going to use a program called EduCase. You'll receive a separate login and password, and you'll get a short tutorial on how to use it. EduCase will give you real-time feedback on your contours using a metric called the DICE similarity coefficient. The DICE coefficient compares a student's contour, contour A, with a gold standard contour, contour B. The DICE score is calculated based on the degree of overlap. The formula is shown here, and you don't need to know it. You won't be asked to calculate it, but what you need to know is that a DICE score of 1 represents perfect agreement, and a DICE score of 0 represents no agreement. Don't aim for a DICE score of 1, that is pretty much impossible. Even if you were to contour a circle twice and compare your two circles, you wouldn't get a DICE score of 1. Generally, a score of 0.7 or 0.8 is good agreement. You'll also be receiving a course manual PDF, which includes annotated radiologic and anatomic images like the one that you see here. Finally, I want to say this: jump in with both feet. Make the most of these lectures, of the labs, and the quizzes. I hope you enjoy the course, and I think that you'll learn a lot.